Good morning, everyone. My name is Gerald DeCosta, co-founder of CETS Technologies. And my background is in IT architecture and most lately within the healthcare industry. So I've seen a lot of the challenges that Vince has articulated up front on a daily basis for the past 6 or 7 years. So what I'd like to do is just kind of set the tone for our strategic partners discussion today, and then let them get into the meat of some of the solutions that they can bring to the table that ties all of this together. The purpose of medicine is to help individuals live their fullest and best lives. And telemedicine is helping providers achieve that outcome with more success day by day. Telehealth is the use of digital information and communication technologies, such as computers and mobile devices, to access healthcare services remotely and manage one's healthcare. Through telemedicine, people are able to more easily get in contact with their care provider. So some of the things that telehealth allows us to do is to use a mobile phone, watch a video, use an app, use an online patient portal to see our test results or schedule appointments, request prescription refills, or email our doctor. We can order testing supplies and medications online, get emails, et cetera, et cetera. So now the goal of telehealth, or also sometimes called e-health or m-health, mobile health, include the following. They make healthcare more accessible to people who live in rural and isolated communities, which is a significant problem that we're experiencing. Make services more readily available or convenient for people with limited mobility or time or transportation options. We see that also a lot as an issue in rural areas. Provide access to medical specialists, and as well as improve communication and coordination of care or continuity of care among members of healthcare and their patients and the team that the doctors have addressing the patient. Some technological or functional examples of telehealth services that may be beneficial for one's health include, and I'm just going to touch on a few of them right now, because this goes into the more technological or the functional aspects of the IT portion of telehealth. One is the patient portal, where your primary care clinic may have an online patient portal. And these portals offer an alternative to email, which is generally insecure means to communicate private medical information. A portal provides a HIPAA-compliant and therefore more secure online tool to communicate with your doctor or nurse practitioner, request prescription refills, review test results, schedule appointments, or request appointment reminders. Another functional aspect are virtual appointments, where some clinics may provide virtual appointments that enable you to see a provider or nurse practitioner online via video conferencing. While these services are convenient, they do have some potential issues. I won't necessarily go into what those issues are right now, because I think most people are really aware of that anyway. Remote monitoring is another area. A variety of technologies enable your doctor or healthcare team to monitor your health remotely. These technologies include web-based or mobile apps for uploading information such as blood glucose readings, devices that measure and wirelessly transmit information such as blood pressure, blood glucose, or lung functioning. Wearable devices are, you're seeing that more now these days with a lot of the Fitbits and things of that nature and health related. Wearable devices that automatically record and transmit information such as heart rate, posture control, tremors, sleep patterns, all sorts of things. Mm-hmm. Home monitoring devices for older people and people with dementia that detect changes in normal activities such as falls. And the early onset of dementia is also related to heart rate variability And that's becoming, as I mentioned the other day, an alarming trend with the early onset of dementia. So these things are tied into cardiovascular and that's issues, and that's a very significant problem that we're having to deal with. There are other things like doctor-to-doctor consultations. You've got personal health records, and a personal health record is a collection of information about your health that you own, control, and maintain. And this is going to be a very important, because all of this is about maintaining, owning, and controlling your personal health records. And a personal health record is an application that is accessible to a patient at any time via web-enabled device, such as your computer, your laptop, or a smartphone. The potential of telehealth and telemonitoring technology has the potential to improve the quality of healthcare and to make it accessible to more people. Telehealth may provide opportunities to make healthcare more efficient, better coordinated, and more importantly, closer to home. Lastly, what I'm going to do is just speak on the current limitations of telehealth. And while telehealth has the potential for better coordinated care, there's also the risk of fragmenting healthcare. So fragmented healthcare may lead to gaps in care, overuse of medical care, inappropriate use of medications, or unnecessary or overlapping care. Other limitations include the fact that insurance reimbursement for telehealth still varies by state to state and the type of insurance. Unfortunately, that's still the case. So what may work in one place may not work in the other. Also, there may be limitations due to regional internet availability or the cost of mobile devices. So some of what we're trying to actually address is that accessibility through the Echo Village centers. And all of this brings us to our fundamental challenge of social determinants of health as it relates to the environment and the economy. If we do not begin to address health in a holistic way, there will be no economy and no country to speak of. Countries have not addressed the quality of care, which in turn creates a hardship to those countries. And we need to address the complete cycle from enterprise to clinic to consumer. And so what we need is a system that ties all of the health-related components, including dashboards for city, county, and region, and we must focus primarily on individual health. The solution must tie the ability to tie into one health ecosystem. And this is what our strategic partner, Lewis James at Emphasis, has for our solution delivery to be included regionally in our Echo Village centers. So I just wanted to set the tone for folks to understand what's telemedicine, telehealth, and the IT component that we're going to have to deal with to, as Vince had said earlier, to address the health issues in our regions and in our nation. So with that, Peggy, I'll turn it back to you.
Okay, excellent, excellent. I see we're going to have a great roundtable after this because COVID and economics and community are definitely tied together. With that, I think what I'm going to do is go to Lewis because we're talking about the telehealth right now, and we're going to round out with Theo. Lewis A. James is the Chief Executive Officer of Emphasis, serving as a strategic partner to provide its software, health and wellness ecosystem to address the prevailing understanding that the global healthcare system is in an Amazon moment, as a long-term impact of COVID-19. So we want to talk about that Amazon moment here. Lewis, tell us about your company and what you do, and what do you see as the issues facing the healthcare sectors and the impact your software solution will have on the market?
My name is Lewis James, and I'm located in Atlanta, Georgia. I'm a degreed accountant, and in my earlier days, along with some other issues, and then made the conversion over into IT because of a position that I had in converting a mainframe system down to a mini computer. A while back, we were introduced to a solution and given the opportunity. It was a diagnostic decision support tool, initially populated with cardiology information. And we were asked, myself and our then chief medical officer was asked to build a business case around it. And this was at one of the HIMSS conferences down in Orlando. And over a period of 3 or 4 days, we went back and reviewed and looked at this presentation. And when we started doing the business case, we saw all of these pitfalls and what happened because it didn't tie into our vision of what healthcare should be about. Now, mind you, our chief medical officer, PhD in biophysical chemistry, MD from Wharton School of Finance, and MD from University of Pennsylvania, and an MBA from Wharton School of Finance and Hospital Administration. Harry kept saying, Louis, this. And so when we submitted the business case, they goaded us on to do additional due diligence into the complete product. Where we thought it was one module, we then found out that this was this immense system that this company had developed at a cost of over $100 million, that this product dealt with not only the interface or the interoperability as relates to diagnostic decisions that the physician provider would make either inside the clinic or wherever care is administered. But the system was designed to take care of every human being from birth to death. If you can imagine a system like that. The system was designed to, when we started looking at the documentation, the second page talked about how do we address life from birth to death? How do we make it a glorious beginning and a happy ending? And so the solution has embedded into it care wherever the patient is located, similar to telehealth. It has a chronic disease care management system that allows for the management of concurrent disease managed by artificial intelligence. But on the other side, because 15% of the world's population are chronically ill, that 15% absorbs 75% of the dollar that's paid every year for health in any country.
Wow.
So how do you then, and that number is growing. So if it's 15% January 1 of this year, by the time this COVID-19 is over, it's going to be 20% of the world's population that's going to have a primary and or secondary or tertiary diagnosis of COVID-19. So in order to reduce or maintain the growth of the expenditure for health, there are only two ways to do it. Either you manage the care better for those individuals who have a primary, secondary, or tertiary diagnosis, or you reduce the number of persons that's going into that health status. And that's what the decision does. Now, earlier this year, both the CDC, World Health Organizations, and a number of other centers of excellence concurred that other than the 15% of the world's population that carries chronic disease, of the remaining adults, it was assumed that 40% would be pre-diabetic. Well, now that number is 70+% of the adult population is predisposed to a chronic disease.
Oh.
Mm.
And so when folks talk about the COVID and pre-existing condition, that's pre-existing diagnosed conditions by a healthcare provider. The problem is that you have this large number of people who have pre-existing conditions that are non-diagnosed. And those conditions could vary from a number of things, whether it's genomics, whether it's the social determinants of health, whatever the case may be, they fall into this category. And so when we started looking at, back when we were looking at the system, we started saying, why are all these components here? Why was a diagnostic decision support tool in place and tested at a 2,000 bed hospital that sees 1.5 million people per year? Why is this system here? And we found out that this diagnostic decision support tool not only diagnosed based upon modern Western medicine, but it also diagnosed based upon concurrently traditional medicine. Mm. So imagine naturopathic, traditional Chinese medicine, lifestyle medicine, any kind of traditional medicine that can be documented and support and imported in this solution. When the physician sees the patient could be treated hypertension with traditional Chinese medicine and diabetes with modern Western medicine. And the system has built inside of it this awareness that whenever there's a contact, whenever there's a conflict, it shows the conflict, advise the provider and the patient so then that the treatment protocols and the diagnosis can be changed. Mm. And mind you, this was done 3.5 years ago. Earlier this year, the World Health Organization defined ICD-11. ICD-11 will allow for doctors to diagnose traditional medicine for the first time. Wow. This solution is already compliant for ICD-11 already. And so, but the focal point in what I want to talk about today is the patient. That the patient consumer has been the weakness as it relates to healthcare delivery systems around the world and driven or exposed by COVID-19. Our healthcare delivery systems can treat you if they know what's wrong with you. But our healthcare delivery system finds it hard to diagnose unknown. But even more importantly, our healthcare delivery systems, as Bill Gates noted at a conference in Cambridge a few months back, our healthcare delivery system is not built around prevention. Our healthcare delivery system says, you get sick, we'll treat you. But the most functional use of a human's resource, a county resource, a state resource, a national resource, let's prevent those number of persons from getting a disease. Let's treat them, let's educate them on lifestyle changes, diet changes. Let's interface that PHI that Gerald talked about, the personal health information, because what most people don't understand is when you go to the doctor and he or she is sitting there questioning you, they're only looking at 20% of who you are. Mm-hmm. 20% of who you are is inside that electronic health record. That other 80%, part of that has a morsel of information that can assist the doctor in providing you care. But the doctor may or may not ask the right question for you to offer up that information. I lived near, when I grew up, I lived near a fertilizer plant. My sister, a couple years younger than me, had one of the lobes of her lungs removed. And then when the surgery was done, this is 20 plus years ago, the doctor says, well, who have you been around who smoke? And she says, no one. My husband don't smoke, I don't smoke, no one in my, I had a brother that smoked, but he smoked away from the house because mom didn't allow smoking in the house. And what happened, what they found out was that the carcinogens that was in her lung were the byproducts of chemical fertilizer.
Wow.
And so that adds into this whole issue around the social determinants of health. So with this solution, and we call it an ecosystem, it's a software ecosystem. I tell people sometimes, I define it as ringmaster. It's a ringmaster system because it has the ability to white light any application that's developed by another company into it. And what white lighting means is that we can take a telehealth application from, say, Amwell, and we can apply an API, an application interface, and we can import that application into the system, and through what they call business consultants agreements, we can now monitor and maintain that data. And when the provider or an individual sees that data, it looks like it's all being populated from one data source. But what this solution has the ability to do, and this solution has 43 patents. Of those 43 patents, 32 of them had to do with data. How do you control data? How do you map back the data? Because data is important. Because if you're going to run analytics, if you're going to assist someone in living a better life, you need to take the data input from all of these different data feeds and present this information in a way where it just looks like a medical diversion of Facebook, except no one can see your medical record because of informed consent and other kinds of consent rules and what have you, or governed by the European Union or whomever the case may be. And that's where the big issue now is. How do we deploy a solution? And what we call, part of our solution is called the Engaged Healthcare Consumer Tool. And this tool aggregates all of the information from wherever you can identify this information may be. So Gerald talked about a physician portal. What this does, I have 3-4 doctors. Now, mind you, I'm pretty healthy. I have a primary care physician, a urologist, whatever. But in order to look at my data, I have to go into 4 portals. With our solution, you sign on to the tool. The tool does single sign-on and attaches to all 4 portals at one time. So I have no need to look at the physician portal because all of that physician's information populates this tool. So that as an individual, in order for a city to be healthy or a community to be healthy, the individual has to be healthy. And what's happening, and we see that individuals in this world, the reason that the COVID is affecting folks so profoundly is that individuals are not aware of their health status. So how do we put technology in their hands that allows for that? The owners of the largest endpoints in this world for patients or individual consumers are the wireless carriers. So in our go-to-market strategy, we're now discussing with wireless carriers as to how do we drive their revenue at the same time driving access to all of these consumers. Folk talk about how do you make healthcare, available from the poorest to the rich, from the richest to the poor. There's one device that from the rich to the poor is consistent, and that is the cell phone. So how do we then take these software solutions and make the cell phone a switch knife? You see, let the cell phone drive access to data. Let the cell phone drive knowledge. Let the cell phone drive, like Metcalfe law says that for one cell phone, I'm connected to 12 people. Okay, so if there are 5.8 billion cell phone connections in this world, we only need 1.6, 1.7 billion connections to attach to every person in this world. And when we make that connection, what then happens, Moore's law kicks in, because with all of these connections and the aggregation of information, Moore's law says that exponentially our knowledge and access to information goes straight up. So instead of taking the comorbidity module that we have that looks at a patient primary, secondary, or tertiary health status and say, here are the probabilities of these diseases that may befall upon you, then let's move that away from someone who has a diagnosed condition and move it into a situation where the individual is not diagnosed, and addressing all of the data inputs into their PHI. We now believe that we can do predictive analysis to look at a person and say, the probability of you becoming a type 2 diabetic is 90% based upon this information right here. We think you need to take this information to your doctor. That's how a company, that's how a country, that's how a state, that's how an individual controls the cost of health, the dollar cost of health, and also the unmonetized cost of the value of your life and your life existence, because you have chronic disease. People always talk about the cost of care, but people have not attached a value to, I'm now diabetic and I've now lost 80% of my life. Well, what does that cost? What does that cost to me as a human being? What does that cost to me as a citizen? And so in order to maximize the value of a healthy community, of a healthy economy, you must go back to the healthy individual.
Mm-hmm. That's awesome. So we're talking about a lifestyle. We're talking about integrating this process into the lifestyle of individuals, correct?
Yes. We're talking about a holistic view, not only lifestyle, but the environmental impact on this particular person and or population. And also putting that knowledge, presenting a dashboard to a county health commission or to a state health commission to say, your community is not healthy, and here are the issues that you have, whether they align with social determinants of health, whether they align with CDC or World Health Standards. Mm-hmm. Here's how you manage your population better.
Awesome. Wow, this is a great discussion, and the roundtable is going to be very exciting because I have a lot of other things I would like to talk to you about. But getting into the next segment of this is making places healthy so that we can get back to the economic recovery. And Theo Cosmora, director of SDG Foundation, serves as a strategic partner and advisor. SDG Foundation also contributes to the fight of COVID-19 by providing, through a partner network, a new laboratory-proven coronavirus eliminating UV LED technology for transport, commercial and residential infrastructure retrofitting, and robot powered by government and office buildings disinfection to enable a safer reopening of nation economies. Theo, this is phenomenal in itself. It is. Tell us about this. I'm very excited about this.
Great, Peggy. Well, thank you for the introduction. And everyone, it's great to be here. My name is Theo Cosmora, and I'm the founder and CEO of SDG Foundation. I'd like to say a quick word, a big thank you to the UN Global Compact for organizing this event. It's an honor to participate and share what we're doing, both with the CETS team and also with our partners worldwide. Our mission at SDG Foundation is simply to enable conscious business, and we define conscious business as a business that is economically sustainable and which in parallel, as opposed to an afterthought, facilitates social empowerment and inclusive economics for a wider society. I've been working around the UN goals for 10 years now, since 2010. And when I helped UNDESA create a solution for the Millennium Development Goals, or MDGs, and for my work there, I received the UN award. Fast forward to 2015 and the SDGs, we have 17 goals instead of 8 goals, which were primarily humanitarian. And industry, business, and academia are included on top of those humanitarian goals now. The SDGs expanded inclusiveness, which was intentional in 2015, will have proven prescient in enabling us to deal with COVID, considering the resources we need to muster from everyone around the world. For likely 500 million jobs and everything that goes with that will have been lost due to this pandemic. We can rightly observe that the two SDGs COVID has most impacted are SDG 3, ensure healthy lives and promote well-being for all at all ages, and SDG 8, promote sustained, inclusive, and sustainable economic growth, full and productive employment, and decent work for all. If we are to recover, we need solutions to directly address primarily these two SDGs among the others. So employing our SDG Ledger platform, which I spoke about yesterday, within the SDG partnership model as proposed by the UN and UNDP, we implemented a holistic 3-point strategy for accelerating a multi-sector post-COVID recovery fund system with best-of-breed tech partners. And with this fund system, it's funded universally by businesses around the world. These 3 points are: number one, a UVC LED robot, deploying the world's most advanced non-mercury polluting UVC LED robot to disinfect work, home, and travel environments. Secondly, UVC LED infrastructure, integrating and retrofitting our advanced UVC LED systems into home, work, and travel infrastructure to make them safe in the new normal for tomorrow. And thirdly, business COVID recovery funding integration, enabling companies to, for the first time, fully integrate the SDGs, and in this context, COVID recovery funding, into their accounting and budgeting systems throughout their supply chain, a world's first. And thus we could universally help to fund post-COVID health and jobs creation recovery. So how do we disinfect our work, travel, and hotel spaces and living accommodation so we can get back to life and work? By deploying the world's first and currently only Mercury-Free UVC LED disinfection robot. It is fully autonomous and has a disinfection rate of 99.999% at 2.5 meters. It is the only UVC robot that is laboratory tested and proven to kill the coronavirus. Its innovative UVC LED only emits UVC rays, which are effective in killing microbes, including viruses such as COVID-19. As well as being unique and patented, this UVC LED technology is much more energy efficient and safe against human skin when compared to conventional mercury lamp-based UVC systems, which emit harmful UVA and UVB radiation. So our partner robot, is the world's first and only mercury-free disinfection robot, because no other robot uses UVC LED in this particular way. All other robots use traditional UV technology in its application. Thus, ours is the only robot to comply with the Minamata Convention. Now, most people don't know about the Minamata Convention. I didn't until recently, but it is an anti-mercury multilateral agreement that was implemented by UNEP, the United Nations Environment Programme. It was so named after the Japanese city Minamata, a symbolic naming after the city's inhabitants suffered from a neurological disease caused by severe mercury poisoning when methyl mercury was released into the city's industrial wastewater by a chemical factory in 1956. You can find a list of the countries signed up to the Minamata Convention, and yours is more than likely one of them, on their website, mercuryconvention.org. Now, there will be many governments, of course, participating at the United Nations General Assembly. All of those 128%, are participating at UNGA this year. So with all other autonomous or non-autonomous robots using mercury-based UV technology, and thus falling foul of the Minamata Convention, how are we poised to implement this throughout society and around the world? Well, CETS Eco-Village platform will use our UVC LED robot to keep public spaces within their campuses clean and disinfected. They will also be integrating this in their infrastructure, which I'll talk about shortly. So check out mercuryconvention.org, and if your country is one of the 128 signatories of the treaty, contact us and trial our UVC LED robot. And now, UVC infrastructure retrofit. As studies show that the virus that causes COVID-19 can live up to 4 hours on copper, up to 24 hours on cardboard, and up to 3 days on stainless steel and plastic surfaces. And that co-working, restaurant dining, and public travel spaces increase the risk of contracting COVID-19. Thus, the need to implement built-in spatial and disinfecting solutions has grown ever more critical and urgent. Now, while we are past the early phase of thinking we could be infected by broccoli and other vegetables in our supermarkets, we do know transmission of COVID-19 can occur through inanimate surfaces when an infected person coughs or sneezes on the surface and someone else touches that surface soon after cough or sneeze within 1 or 2 hours. If we want to keep people safe, all public spaces in our post-COVID-19 era will need UVC LED retrofitting. And this is why CETS eco-villages come with our UVC LED disinfecting lamps fully integrated into all buildings and living and working environments. We believe UVC infrastructure retrofitting will generate literally millions of jobs around the world as we adapt to the new normal, and all buildings, travel infrastructure, living infrastructure are retrofitted with UVC LED. We enable you to upgrade spaces with our advanced UVC LED solutions, such as new building developments, public transport lighting, and office and restaurant environments. So do please contact me, Theo, at sdg.foundation to learn more specifically about this. Now, to finance all this infrastructure UVC retrofit, we need something special. It's one for all and all for one. It's all hands on deck. This is the only way. We have to decentralize and include all parties to participate in funding this new normal for tomorrow. When I presented yesterday, I mentioned that today business is programmed for quarterly financial currency targets. I asked, what if we were to add social currency quarterly targets and environmental currency quarterly targets? Mm-hmm. We know this would bring massive transformation to our world. And so many people want this. We need to shift from the single bottom line of profit and profits only to the triple bottom line of people, planet, and profit, all equally viable currencies in humanity's lives. But now we really need this because we need all hands on deck, as I was mentioning, to help fund post-COVID recovery. SDG Ledger, which I presented yesterday, provides a complete platform for exchanging SDG budgets and investment compliance accounting documentation with full traceability. With this system, as an example, a quotation made by a supplier can be converted into a purchase order by the client and sent back to the supplier. The supplier can then use the same data to convert the purchase order into an invoice and delivering it, fully automated. Mm-hmm. Both parties can use this transaction to dynamically allocate SDG COVID recovery budgets directly and in real time from within their supply chains. SDG Ledger also handles different charts of accounts used by all businesses in different regions, and at the same time provides for a full SDG integrated chart of accounts budgeting system that can be tailored to COVID recovery funding. As SDG Ledger is available in 33 languages, and so it's perfect for international trade and supply chain support, it can help to coordinate a business-integrated global COVID recovery funding effort, including funding of new job creation for retrofitting infrastructure. And finally, an SDG marketplace that can be integrated into companies' systems and platforms with a partner back office. If you have a COVID recovery solution, please contact us to launch it in the SDG marketplace. We believe only when the triple bottom line model is fully integrated into accounting and budgeting systems in business can we collectively lose what Albert Einstein refers to as an optical delusion of consciousness, where we care only for those closest to us. And companies truly have a social and environmental purpose as well as a financial one. Only with this full integration can we collectively, in real time, while doing our business, not as an afterthought, bring about the better world that we need. For more information, please contact me, Theo, at sdg.foundation. Thank you.
Thank you, Theo. That was absolutely awesome. So I just wanted to let everyone know who's on this session to know that this is historic. The things here that we're revealing and debuting, it is a new revolution, building from the ground up and not the top down. And I wanted to we have time enough for the discussion here with Vincent and everyone. Let's talk, Vincent and Gerald and Theo and Louis, about bringing this full circle. We're talking about a circular economy. We're talking about a reset. How do you see from the first session, let's bring all of this in together with CETS.
Okay, I'd like to jump in. CETS, it all stems from the environmental and waste management. It's always the key. The hospital waste right now is in abundance, as we may know. And that waste, hospital waste or medical waste, is costing the healthcare sector over a third, close to half of its budget at this point in time. When you include this overhead, not only just the disposal of that waste, but the insurance risks and all of those intangibles, we're talking about half of its budgets. What CETS is creating in its circular economy using the waste streams, we're able to take that medical waste on site and dispose of it and turn it into renewable energy and byproducts for its PPE, supply chains, and so forth and so on. So infrastructure and environmental tied to the human as well as the economic construct is very important post-COVID. Mm-hmm. What we're finding out is that even the sludge waste or the human waste, the COVID is traveling through our pipes into our sanitation systems, where it's causing the sanitation workers at the waste transfer plants getting COVID, because it's all linked together. When we talk about handling the waste streams on site, that means the waste never leaves where it's being produced. It's all recycled back into an ecosystem, and creating a more efficient and effective and healthier way of disposing of our waste streams. And as we tie that into that physical structure, it also provides a safer delivery for our virtual supply chains for managing and tracking and linking all of the necessary solutions to deliver a more holistic approach to healthcare and our planet, saving our planet as well as our human capital. So I had to kind of throw that waste management component in there, which is very critical in these times, and how we manage that and try to stabilize those cost line items on those budgets for those delivery systems. So that's what I have to say on from that standpoint, and bringing it full circle, where we talk about delivering a physical structure that's not only environmentally safe and healthy to service our customers, to live, work, and play, but also make it sustainable, where we don't have a 15, 20-year return on investment, but a 2 to 3, because technology is moving so fast. Municipalities and governments cannot afford to invest in something that takes 5, 10 years to get a return on its investment. Technology is moving too fast for that. Nanotechnology is coming on real strong. You're not really hearing about that, but nanotechnology is scaling down our ability to really get a better return on that investment, and making it more cost effective to scale up globally.
Okay, awesome. So, Louis, we're talking about social and economic recovery because I think that's the most important thing that society has to do. People have to interact, and COVID has impacted that 1,000% with the social distancing and quarantines and all of that. And I think what you and Theo are presenting, and Theo completely, is helping us to get back to a new normal, not the regular normal. How do you, Louis and Theo together, how do you feel that your two components can interact together with CETS to help with the circular economy? And Louis, you could go first.
Well, again, I go back to the impact on COVID and what has to be addressed now, today, for individuals and or governments, is how do we get people healthy and healthy now and start that process. And everything that aligns with that then falls into the complete circle, right? That if you don't have a healthy person, because that person doesn't live in a healthy environment, so Theo product then provides that environment that individuals can work and live in, then none of it makes any sense, because next year this time there are going to be millions of people dead or carrying this COVID-19 as a pre-existing condition for the rest of their lives. The irony of it is like Vince just says, it's in the waste. Well, guess what? It's in the semen of men. So now we're talking about this virus being able to be, now it's transmittable through semen. I mean, just think of that. And so what countries and individuals have to do right now is to put processes and systems in place to address that, and then let the rest of it evolve. Because if you don't have the people, it doesn't matter about the environment, because there won't be anyone around to live in the environment. Think about it, okay? I mean, so when I think of what Theo was doing, I was thinking the other day when I first read about what his company did, I says, okay, how do we use that? Well, we use that by tracking it. We track those individuals who work in those particular locations. Are they getting sick? If they're not getting sick, then we know that company B or train station F that I go through every morning, or whatever the case may be, if his robots and other apparatuses are providing the cleansing for me, it then means that I live in a healthy environment. It then means that I'm a healthy individual. It means when I go back home, I carry back home a healthy person. And that becomes part of my, smart health community, right? And so from the advantage, from the viewpoint of organizations, I mean, we now know this morning that the COVID-19 is on the uptick everywhere in this world right now. We need to do something now. Okay, we need to act now, because acting next week or after an election or whatever the case may be, just think, in the United States, they're projecting that 200,000 people, more people are going to be dead in the next 90 days. Okay, I know of 20 people that's died. You know, I mean, so how many more people am I going to know, or am I going to be in that number? You see what I'm saying? And so how do we tell and propose to entities that you need to react now, because not reacting now doesn't allow you to have the capital, whether it be human or otherwise, to do something 6 months from now?
Mm-hmm. Well, do you think what about pre-existing conditions? You think that most of the people that have died have had pre-existing conditions? And if they do, how do we socially track that? Do we use artificial intelligence, Internet of Things, their clothing and things like that? We could monitor people.
We use all of them. I mean, the Internet of Things, the Internet of medical things or health things, we can monitor Theo's devices as to where and what building the robots are at a particular point in time in neutralizing the virus. That then can feed back to individuals. But the irony of it is that most individuals, it's not the pre-existing conditions, because folks with pre-existing conditions are trying to protect themselves. It's those individuals who believe that I don't have a pre-existing condition, so I am not one of the ones that's likely to get it. But when you stop and you talk to people, or you listen, or you read these CDC documents and these readouts, you see that these long haulers and these other individuals that may have survived this thing, that they in fact had pre-existing condition. You know, I saw a lady yesterday that said she survived it, which was great. And she was a healthcare professional, and she had no pre-existing condition. But I'm looking at her and I'm thinking, yes, you do. Because you're morbid obese. You see what I'm saying? I mean,
right.
You see what I'm saying? So
understood.
You have diagnosed pre-existing conditions and undiagnosed pre-existing conditions. Like I said, World Health Organization, CDC, a number of centers of health excellence around the world have said that outside of that 15% of this country, of the world, of the population that carries a chronic disease, 70% of the adult population has a non-diagnosed pre-existing condition.
Wow.
Okay, and that's frightening. And so,
well, how do we get the healthcare industry to recognize this and get this information out to the people?
The healthcare industry is not designed for prevention. You know, that's why lifestyle medicine is around. That's why people are going back to a more holistic way of eating, because our body is designed to heal itself. We can't grow a limb, but most of our organs have the ability to either heal itself or grow itself back. So think about it. Most medicines are synthetics. Our bodies are not designed to deal with synthetics being injected into it. It's just not. And so if I take a medicine that addresses hypertension, it's tearing down some organ in my system. That's why we have these comorbidities, because our bodies are not designed to handle synthetics, period. It's just not. And our system, modern Western medicine by design is designed to treat people once they're sick. It's too late.
Correct.
It is too late. How do we keep, I sat and I watched New York City and all those folk that were dying and what have you. And I'm thinking, wow, this is going to happen everywhere. How do we inform the janitor that maybe instead of him eating a cheeseburger every day, that maybe he would be better off by doing a smoothie, an organic smoothie, and putting that in his system, because it assists him or assists his organs and his body to maintain a better immune structure. I'm sorry,
No, you're totally and completely right. And we actually had a wonderful discussion the very first day, correct, Vincent?
Yes.
And Gerald, on the agri industry with Ann Alexis, and people can go back and see that, because it starts with what you put in your body.
Right.
It starts with food, the food that we, put in our bodies. So you're totally right. And that's why I love the circular economy and CETS, because it's addressing all of those industries and issues together. And Theo, the question I have for you, how would we implement your robot into the residential world for people? We're talking about commercial, but how would it be used if someone in a residential facility wanted to use it?
Sure, I'll answer that. A very quick thing on what you mentioned about we are what we eat. We also need to look at the farming industry, and especially how the meat industry. I'm a vegetarian for many years. I'm a raw vegan since 1999, and the meat industry causes a lot of damage in humanity. So we really need to look at that. Anyway, so back to your question.
I agree with you. Totally and completely. I'm vegetarian as well.
Back to your question. The beautiful thing about what CETS is doing is it's a perfect best practice example of how we can integrate this technology into all aspects of human life, living, working, and playing. The eco-village design that Vince has already started to implement. We've already started to integrate our UVC LED technology into those designs. And so when CETS deploys its eco-villages, every ceiling, every bathroom, every environment that could possibly be either a breeding ground or a contagion space for COVID will have these UVC LED lights built into the infrastructure. So the CETS Eco Village will actually be the world's first total living and working environment with fully integrated UVC LED technology. Now, that's a very significant achievement.
Awesome.
That CETS
awesome.
Eco Village is going to enable. Now, they have financing for their initiatives. Of course, the wider global population is critical here. After the war, massive amounts of funding was implemented to fund regeneration of infrastructure in Europe, in America as well. And we don't have that now. What we need to do is we need to integrate funding for COVID-19 infrastructure integration with UVC LED in a manner where everybody pays a tiny bit. And the way to do that, as I mentioned in my presentation, is to integrate this into budgets and supply chain transactions. If a penny per transaction is set aside by all businesses around the world, we would have this funded. The current funding mechanism, let's look at what's happened in the early part of 2020, when to anyone looking at what's happening in Wuhan, and just understanding how this virus was spreading, it was obvious it was going to go west. Obvious. And yet for 3 to 4 months, no one did anything. By the time it was fully blown in Italy, unfortunately, even then in England, here, people were going to concerts. Everyone was partying. It's not surprising that the UK has one of the highest per capita deaths rates. It's tragic. So preparation is fundamental. And this is a sign, I think, we're going to have more of these viruses come in the future. This is not the last one, right? We've been very lucky. The last big one in the West was 1918, all right? In Asia, they had SARS and had 1 or 2 others. So this is why countries like South Korea, like Taiwan, like Singapore, they are not experiencing a second wave now. They're disciplined enough to protect themselves. And globally, we need to realize that we need new infrastructure, just like CETS eco-villages are coming pre-programmed with this disinfectant infrastructure in place. We need to devise a methodology whereby all parties around the world can contribute 1 penny at a time to a regional or a local fund. This can't be top down. It needs to be ground up, all right? It needs to be communities and businesses around the world putting a penny aside to fund infrastructure integration of UVC LED. And ours, as I said, ours is the world's first laboratory proven and tested solution that verifiably eliminates COVID-19. So we can deploy this as lamps, as tabletop solutions, as personal solutions, as large infrastructure solutions, as infrastructure lamps for trains, for planes, for office buildings, etc. We've got to integrate this into the infrastructure so that it becomes part of the infrastructure.
Right.
And that's the future for humanity. These viruses are going to get worse, stronger, etc. And with the CETS eco-village design fully integrated with this, it's a perfect example for people to go and see how they've done it.
Thank you, Theo. Thank you. Gerald, do you have something to say in closing? Because we're going to wrap up here.
Yeah, we're over time now. I mean, I think most of what has been said is we need to really look at this thing in a holistic perspective. And it starts out with our individual health, and that starts out with what we eat, what we consume, and how it affects the environment. So we cannot have, as I said before, we cannot have a healthy nation or state if our own systems are compromised and we're carrying diseases. So from a very holistic perspective and from a circular economy paradigm, we have to include all of the different elements and attributes that Lewis, Theo, and Vince have articulated earlier. So that's pretty much it. And a lot of that comes down to education and exposure.
Yeah.
And I think what Theo is bringing up about this ability to finance, with a penny or whatever type it is, whatever that can be, it's a great idea, but it does have to be included in the infrastructure. It's no question if we're going to try to beat this thing and make the place and make our world a healthier environment.
Correct. Vincent, I wanted you to, since we're talking about deployment of eco-villages, could you wrap up a little bit, let people know where we're starting, where CETS is starting, the proof of concepts? Because we're talking about rolling out 500, correct?
That's correct. We're rolling out 500 and we're putting out a request to join us, and we're recruiting 100 nations to participate in our global carbon emissions reduction program for the implementation of a net zero circular economy paradigm. We want to be able to put in 5 case studies within those 100 nations. We joined the global compact because they were looking for the private sector to bring scalable solutions to the table for those 198 countries that signed the Paris Accord. So this is our model for scalability to be adopted and implemented within those 198 countries. We stand ready, willing, and able to provide our solutions, and we're putting out our requests for 2 million private sector participants to also join us in engaging and joining forces with us as a participant as well. And then that feeds into what Lewis is talking about. We need the individual to join and so they can be part of this healthy living and getting on our software so we can start tracking you and making sure that you're healthy as you navigate this very toxic environmental world until we get it all straight. So we're putting out a request to the government officials to join us as a strategic partner, as well as the NGOs and the citizens of the world to let's get on board and push this rock uphill together.
Thank you so much. Well, this is the ending. I wanted to thank the UN General Assembly, UN Global Compact for having us. This has been a phenomenal 3 days with these experts and our partners, strategic partners. I would love to invite every one of you to please engage with these experts, engage with Vincent, Theo, Lewis, Gerald, myself, and everyone that has been a participant or a partner in this. Please, you can visit our pavilion, go to the pavilion and visit our booth, and you can engage there. I want to thank all of you. This is a very serious topic, and the solutions are right here. So the solutions are right here. We just have to implement and reset. I always say we're at a reset. We're at a time in humanity where we have the opportunity to recreate the world in a way that we envision it, a better world for all of us globally. And I want all of you to think about this when you leave, how you can make the world better. And let's engage and come together as one. I'm going to close the session out. Thank you all for attending.
Thank you.
Please engage with us. God bless you all. Stay safe. And hopefully we'll see each other in person one day soon. Thank you so much.
Thank you all. Thanks again. Louis,
Thank you. Thank you, Louis,
Bye-bye.
Theo,
Yep.
Vincent, and
Thank you.
Gerald. Thank you all. Have a great day.